Hello and welcome to the topic Dyslipidemia in the Cardiology module. By the end of this session, you should be able to define dyslipidemia, classify and elaborate the different types of dyslipidemia based on its elevated components, outline the causes for dyslipidemia, describe the approach to establish a diagnosis of dyslipidemia, and finally outline the principle of management of dyslipidemia. Let's get started. Dyslipidemia is the elevation of plasma cholesterol, triglycerides or both, or a low HDL cholesterol level that contributes to the development of atherosclerosis. A practical system to categorize dyslipidemias is based on the specific type of lipid that is increased. For instance, isolated hypercholesterolemia is the increase in cholesterol only. Isolated hypertriglyceridemia is the increase in triglycerides only, and combined hyperlipidemia is the elevation of both cholesterol and triglyceride levels. This particular type of classification helps narrow the disease based on the clinical presentation as well. Dyslipidemias may be primary or secondary. Primary causes are single or multiple gene mutations that result in either overproduction or defective clearance of triglycerides and LDL, or underproduction or excessive clearance of HDL. Secondary causes are the major contributors to dyslipidemia in adults, and the most important secondary cause of dyslipidemia is in developed countries are sedentary lifestyle with excessive dietary intake of saturated fat, cholesterol, and trans fat. And other common secondary causes include diabetes mellitus, alcohol overuse, chronic kidney disease, drugs such as thiazides, beta blockers, retinoids, highly active antiretroviral agents, cyclosporin, tacrolimus, estrogen and progestins, and glucocorticoids. Now let's look into the familial hypercholesterolemia type. What happens here is that there is a reduction in the receptor-mediated clearance of LDL due to the mutation of 3 genes, as you can see in this slide. Abnormalities include elevated LDL cholesterol levels and total cholesterol. It follows an autosomal dominant inheritance pattern. Clinical signs include tendon xanthomas of the Achilles or extensor digitorum tendons, corneal arcus, xanthelasma, planar cutaneous xanthomas, and aortic stenosis. The cardiovascular risk associated with this condition is very high. It affects 50% of males by the time they are 50 years old and 50% of females by the time they are 60. Children with parent with familial hypercholesterolemia should get screened by the age of 10. Next is familial combined hyperlipidemia. This condition happens when there is an overproduction of very low density lipoproteins and ApoB. It is the commonest type of dyslipidemia. You will find an elevated LDL level and/or TG with low HDL levels. Clinical signs are non-specific, and premature coronary artery disease is common and occurs in those less than 60 years old. Next would be the familial remnant or type 3 hyperlipidemia, or also known as familial dysbeta-lipoproteinemia. Here what happens is there is a reduction in ApoE2 liver receptor-mediated remnant clearance. It is autosomal recessive inheritance and poses a very high cardiovascular risk. Clinical signs include striate pulmocresis and tuberoeruptive xanthomas. Cardiovascular risk is very high. Last but not least, familial hypertriglyceridemia. The mechanism behind this condition is unknown. Prevalence is about 1 in 100 people. You would expect an elevated triglyceride levels. Clinical signs include eruptive xanthomas and lipemia retinalis in severe cases. High levels of triglycerides can cause acute pancreatitis. Patients with severe elevations of TGs also can have eruptive xanthomas over the trunk, back, elbows, buttocks, knees, hands, and feet. Severe hypertriglyceridemia can give retinal arteries and veins a creamy white appearance known as lipemia retinalis. Extremely high lipid levels also give a lactescent or milky appearance to the blood plasma. High levels of LDL can cause corneal arcus and tendinous xanthomas at the Achilles, elbow, and knee tendons and over metacarpophalangeal joints. Other clinical findings seen in patients with high LDL include xanthelasma, which is a lipid-rich yellow plugs on the medial eyelids. Patients with a rare dys-beta lipoproteinemia can have PAMA and tuberous xanthomas. When measuring lipids, both with total cholesterol and HDL should be checking to provide the most accurate risk of cardiovascular disease. A full lipid profile also should be checked, including triglycerides, before starting statins. The samples taken do not need the patients to be fasting. In the vast majority of patients, the cholesterol measurements will be fed into the Q-RIS2 tool. If, however, the patient's cholesterol is very high, we should consider familial hyperlipidemia. NICE guidelines recommend the following: that we should consider the possibility of familial hypercholesterolemia and investigate further if the total cholesterol concentration is more than 7.5 millimoles per liter and if there's a family history of premature coronary heart disease. They also recommend referring people with a total cholesterol of more than 9 or a non-HDL cholesterol of more than 7.5, even in the absence of a first-degree family history of premature coronary artery disease. The management of dyslipidemia is largely divided into primary prevention and secondary prevention. For primary prevention, a systematic strategy should be used to identify people aged over 40 years who are likely to be at risk of cardiovascular disease, defined as a 10-year risk of 10% or greater. NICE recommends we use the Q-RIS2 cardiovascular disease risk assessment tool for patients aged less than 84 years. Patients who are 85 years and above are at high risk of cardiovascular disease due to their age. NICE now recommends we offer a statin to people with Q-RIS2 10-year risk of more than 10%. Atorvastatin 20 mg should be offered first line. Type 1 diabetes mellitus. NICE recommends that we consider statin treatment for primary prevention of cardiovascular disease in all adults with type 1 diabetes. Atorvastatin 20 mg should be offered if type 1 diabetics are older than 40 years or have had diabetes for more than 10 years or have established nephropathy or have other cardiovascular disease risk factors. As for secondary prevention, all patients with cardiovascular disease should be taking a statin in the absence of any contraindication. Atorvastatin 80 mg should be offered as first-line therapy. NICE recommends we follow up patients at 3 months, repeat a full lipid profile, and if the non-HDL cholesterol has not fallen by at least 40%, concordance and lifestyle changes should be discussed with the patient. NICE recommends we consider increasing the dose of atorvastatin up to 80 mg. These are many ways predictable by NICE make a number of specific points. Cardioprotective diet. A total fat intake should be less than 30% of total energy intake. Saturated fats should be less than 7% of total energy intake of dietary cholesterols, and that should be less than 300 mg a day. Saturated fats should be replaced by monounsaturated and polyunsaturated fats where possible. Replace saturated and monosaturated fat intake with olive oil, rapeseed oil, or spreads based on these oils. Choose whole grain varieties of starchy food. Reduce your intake of sugar and food products containing refined sugars including fructose. Eat at least 5 portions of fruit and vegetables per day. Eat at least 2 portions of fish per week, including a portion of oily fish, and eat at least 4 to 5 portions of unsalted nuts, seeds, and legumes per week. As for physical activity, each week aim for at least 150 minutes of moderate intensity aerobic activity or 75 minutes of vigorous intensity aerobic activity, or a mix of moderate and vigorous aerobic activity. Do muscle strengthening activities on 2 or more days a week that work all major muscle groups, in line with the national guidance for the general population. As for weight management, there's no specific advice is given. However, overweight patients should be managed in keeping with the relevant NICE guidelines. Alcohol intake, again, there's no specific advice other than the general recommendation that males drink no more than 3 to 4 units a day and females no more than 2 to 3 units a day. As for smoking cessation, smokers should be encouraged to quit smoking. In summary, dyslipidemia refers to the state of elevated plasma cholesterol, triglycerides or both, or a low HDL cholesterol level that contributes to the development of atherosclerosis. Dyslipidemia is here classified based on the type of lipid elevation. This condition can be linked to genetic mutations or secondary to lifestyle and environmental factors. Common familial causes are familial hypercholesterolemia, familial combined hyperlipidemia, familial remnant hyperlipidemia, and familial hypertriglyceridemia. Diagnosis is made based on serum lipid profile and clinical findings associated with lipid deposits in the body. Treatment is started for patients taking into consideration their risk of cardiovascular disease and if the patient has type 2 diabetes. Non-pharmacological approach, which include dietary changes and exercise, should be advocated to all patients. We have come to the end of this topic. Thank you.